Alright, good, we are live. Okay, good evening everyone. This is Meet the Specialist episode 5. Today we have Professor Dr April with us, who is the Dean and also a General Surgeon in UMMC. Right, so just give it a few more minutes before we actually start at 9 p.m. We would like you to subscribe to our email mailing list, especially UM medical students, and you can follow us for more updates through our Facebook and also Instagram. Sorry for that. Again, for those who just joined us, good evening. I hope everyone is doing well in this. Some of us are in MCO, some of us are not, but nevertheless, hope that everyone is doing well. Take care and abide to the SOPs. Right. So how many audience do we have now? 37. Great. So we started off our Meet the Specialist sessions last year. We started off with episode 1 was internal medicine, and episode 2 was neurosurgery. Besides that, we covered also obstetrics and gynecology, and this is the 5th episode. So in terms of the UM Medical Society, we are a student society under the Faculty of Medicine. We're all medical students, and we believe that medical students have a role that we should step up to, and what we believe in is from students, for students, and also we hope to improve the relevancy and also the sustainability of our society. Right, so for those who just joined us, we're having our Meet the Specialist session. Today, Prof Dr April, who is a general surgeon, will share with us what is general surgery, what are the pathways, how is it like working in general surgery, and whether is there a work-life balance, whether does that really exist in surgery. Okay. Right, so we have someone from Indonesia tuning in. Welcome. Alright, good evening everyone. It's 9 p.m. So today we are doing Meet the Specialist. Our topic today is general surgery. Today we are very honored to have Professor Dr. April with us who is a colorectal surgeon in the University of Malaya Medical Center. So before we start, if you would like to follow us for future updates, please do follow our Facebook, Instagram, and also especially for medical students, please subscribe to our mailing list so that you can get the latest updates by our society. Okay. Right. Okay, so my name is Chiang. I'm a fourth year medical student here in University of Malaya, and I'm very honored to be invited as a host today. Thank you, UN Medical Society, MEDSOC, for giving me this opportunity to host an amazing speaker and an amazing session. And I hope to see more sessions coming out after this. Right, so before we start, there are a few ground rules that I hope everyone can follow. Is that I would like to remind everyone that this event is live on our Facebook, and you can ask your questions in the comment section under our Facebook Live. And I would like to remind everyone to be respectful at all times. And we will also send a feedback form after the session so that you can help us to improve on our future sessions. And I would like to now take the opportunity to introduce our speaker today, who is Professor Dr. April, who is the Dean of our Faculty of Medicine in the University of Malaya, and who is also a senior general and colorectal surgeon under the University of Malaya Medical Center, and also a president for the College of Surgeons under the Academy of Medicine Malaysia. Good evening, Prof.
Hi, everyone. Good to see all of you on board.
So, Prof, can you hear me clearly?
Yes, there's a little bit of background noise, a bit of echo, but otherwise quite clear.
Okay, right. Okay, Prof, would you like to start off with, would you like to do a self-introduction for us and tell us why did you feel that surgery was your field?
Well, I've always been someone who has tried to marry art with science, even as a child, although in school I was streamed into the science stream, but I always tried to have a lot of curricular activities that were to do with the arts, and so that's always been part of my ethos. When I went to medical school, surgery was one of the subjects that I really enjoyed. But I have to say that the environment then was very different, and we certainly didn't get much encouragement to enter into surgical training. And in fact, I don't think I ever saw a female surgeon at all during my time in medical school. So much so that when I came back to Malaysia and I was being interviewed for a house job, at the Ministry of Health, and the interviewer asked me, so what specialty do you see yourself going into? And I sort of said, well, definitely not surgery. So that just goes to show that, it's who you see, it's who you come into contact with, and who really inspires your passion in the subject. So what really turned the corner for me was when I did my rotation as a house officer in surgery, and that was actually in the university hospital as it was known then. Okay, UMMC was known as the university hospital, and really what struck me was the whole team approach. It was very much teamwork. There was a lot of camaraderie, and it didn't really matter what level of seniority you were in. The house officers, we were as much part of the team as the specialists and the consultants. And in fact, in those days, as a house officer, you were allowed to perform appendectomies, and so I did my first appendectomy as a house officer. So I think that's what really inspired my passion into it. The fact that it was very technical in terms of the skill and the craft of surgery, but at the same time there was an art to it. That's why you would see that there were some surgeons that were just better than others, but it was not even just that. It was the whole patient approach and the whole team approach. So it was really that attracted me to the field.
All right, thank you, Prof. Thank you for sharing that to us. Next, we would like to explore and we'd like to ask Prof. So this is for the viewers who might be first year, second year in medical school. So, Prof, can you tell us what does a general surgeon do?
That's a loaded question because, to be honest, the definition of a general surgeon has changed over the years. Okay, so when surgery first became a specialty, everyone was a general surgeon, and basically a general surgeon, all kinds of surgery, from head to toe. But clearly, as we learned more about medicine and surgical techniques, and as we refined our approaches, and the craft itself became much more specialized, much more technical. The learning curve for each branch of surgery became more specialized. It was no longer possible for one person to train to the highest degree of expertise in each of these areas. That's why you started having specialties branching out and becoming a specialty of their own, like you would have orthopedic surgery, you have cardiothoracic surgery, neurosurgery, etc. But what it was in the beginning was that everyone trained as a general surgeon, where you learned sort of at least basic care of common surgical conditions and basic operations as well. So you could actually handle most common emergencies. So even if you wanted to become a neurosurgeon, you had to train in general surgery first before you went on. But as I've said, the degree of specialization, the fact that there was, even within that specialty, there were then sub-specializations going on with the advent of technology being used in surgery. It was no longer possible for us to do that, because you would end up being 50 before you actually became a consultant. So what happens now is that, at least at the early level, you do a little bit of basic training, which allows you to acquire basic skills, suturing, knotting, that sort of thing. And then you go into your specialty of choice. So what is general surgery today? General surgery today, it actually addresses those special areas that have not yet developed as their own specialty. Okay, so to all intents and purposes, in Malaysia, general surgery is the route that eventually gives off branches of subspecialties like breast endocrine surgery, colorectal surgery, upper GI surgery, vascular surgery, and hepatobiliary surgery, as well as trauma. So in Malaysia, that's what general surgery means. You do your surgical training probably in a master's program, which is about 4 years. And then if you choose to, you can continue to practice as a general surgeon. So you will see all the sort of common emergencies and common general surgical conditions. But if you want to be a sub-specialist, you then have to undertake a fellowship in your subject of interest.
I see, Prof. So it has turned from earlier, in the earlier days, everyone is a general surgeon. We have to do something. We have to do general surgery before any sub-specialization is allowed.
Yes.
It's like a part in a pathway. But now we are
Yes.
seeing that these subspecialties have their own pathway themselves. with
Well,
incorporated with some general surgery components. Is that right?
well, a subspecialty means it's a specialty of general surgery. General surgery is a specialty. Urology is a specialty. Neurosurgery is a specialty, and so on. Okay, so when you call it a
Right.
specialty, it means it has its own training pathway, and they don't overlap anymore. Okay, whereas if you're doing general surgery as a specialty, you can then go on to sub-specialize in breast, endocrine, colorectal, etc. Yeah.
So, Prof, does the general surgeon in general say if, for example, if a certain center does not have sub-specialized surgeons, do the general surgeons perform everything from breast, endocrine, colorectal to upper GI?
That is
Is
correct.
that the case? All right.
Yeah, that is
Okay.
correct. And in fact, that was what I was doing for some time after I qualified as a general surgeon. I was basically doing general surgery, so everything for a few years until I decided to subspecialize in colorectal surgery.
I see, Prof. Okay, Prof, we'd like to know, because we know that surgery has always been known as a very hectic, very busy specialty. So actually, how frequent are on-calls and emergency surgery? Because we understand that this changes as we move on in our careers. As in, we might start off with very busy, hectic schedule, and as we move on, it becomes more and more manageable. So, Prof, how frequent are on-calls and emergency surgery, and how is the frequency different in different stages of our careers?
It's very variable, and much of it depends on what your staffing strength is. If you look at it from the perspective of training, if you're a trainee, in order for you to acquire enough clinical exposure and to get enough cases under your belt, what we recommend is that you should be doing at least 6 to 7 calls a month. Okay, so that's maybe on call twice a week, something like that. Okay, when I was training, there were periods of time where I was doing a 1 in 2 rota because there were only 2 MOs to share the calls. And during that rota, I was not only covering general surgical calls, but I was also covering neurosurgery, pediatric surgery, urology as well, because they didn't have enough MOs to cover everything outside of office hours. And when I was doing cardiothoracic surgery, we would be on call for 2 weeks at a time. So I had to stay in the hospital for 2 weeks at a time. So it was, I would say it was pretty painful. And it's just the fact that you were working with a good team and we kept each other's spirits up, but it was really quite stressful. Then when I qualified and I started work, again, I was doing something between a 1 in 2 and 1 in 3 on call. So about 10 calls, 10 to 15 calls a month. It was tough. And so I suppose won't wish that kind of life on anyone. It does amuse me sometimes when my trainees and my lecturers complain about how many calls they have to do. But clearly, it's not something that is sustainable in the long run. You will burn out and you may start making mistakes when you're too tired. Okay, so really what I would recommend is around 6 to 7 calls a month, especially when you're in the beginning stages of your career. Once you're well established and you're a consultant in your field, the calls change because you're no longer, at least for us, we're no longer on active calls where we have to stay in the hospital. So consultants at the moment, we are on passive call, which means we are on standby, but we are at home. And oftentimes I would have a senior lecturer on call with me as a clinical specialist who is also usually quite an experienced surgeon, and therefore it is rare nowadays that I would have to come in to see the patients or to operate on the patients. It's usually just a phone call and they just want to confirm that the plan of management is appropriate. Yeah, so it's better for me now in terms of the number of calls and also what I'm expected to do on the call, but it's counterbalanced by other sorts of work increasing, like the administrative aspects, you know, the strategic planning, the people management and all that. So I would say that we were doing this calculation as to how many hours we all work. We discovered that actually there's not much difference between the specialists and the consultants. We're just doing different kinds of work now.
Right, so there's a very obvious difference on the type of work that that is being done as we move as a surgeon progress throughout his or her career. But it seems like the amount of time is dedicated to the work is just around there. It's almost the same. Right, Prof,
yeah, and it's
earlier,
also quite variable. It's also quite variable depending on which setting you're in. So for me, I might not be doing as much of the general surgical on-call as I used to, but I do have to attend to the UMSC private patients. And so that's a different kind of scenario. A colleague of mine in a Ministry of Health hospital, which is perhaps not as well staffed, might still be doing 15 days a month or even every day in some specialties. So it is really very variable depending on your setting.
all right, thank you, Prof. Prof, earlier you mentioned about the reason why you picked surgery was that it, as your back in your formative years, you were always attracted to things that combines some arts and science, and you did see surgery as a field that requires technicalities and skills. So, are there any other essential characteristics that or traits that a general surgeon should have?
Yeah, so you really have to be the whole package, right? It used to be thought that you just needed to be very technically skilled, okay? But if you actually look at the literature surrounding patient outcomes, it's clear that skill is only one part of it. You also need to be able to make decisions. Okay, you need to have good communication skills. You need to be able to work in a team, and you do need to have leadership qualities. So all of these things that we talk about, you know, the knowledge, the skills, the behaviors, all of this is what we call surgical professionalism, and that also includes things like integrity. So really, to be a good surgeon, you need to be the whole package. It's not just one thing or the other. And so that's why now in surgical training, we don't just focus on the technical skills. We're actually running courses also on non-technical skills, which covers those areas that I mentioned, you know, situational awareness, decision-making, teamwork and leadership.
I see, Prof. Okay. Right, Prof. Besides being the president of the College of Surgeons, I understand that you are also the chairperson of the Women's Surgeon Chapter. Would you like to tell us more about that?
Yeah, so this actually came out of numerous discussions that I've been having over the years with students, trainees, you know, fellow surgeons, and what became apparent, especially when we look at the situation across the world, is that there is still a big disparity in the numbers of women in surgical specialties, okay? Particularly when you look at medical school enrollments, where across the world you're looking around 60%, even 70% in some countries, enrollments in medical school being female. And yet, when you look at surgical specialties, those proportions don't hold true. And I was just really interested as to find out why that was the case. And you know, the sort of responses I got from my fellow male colleagues was that, oh well, you know, it's not, women don't like doing it. You know, they'd rather have jobs which are more office hour related, so that they can raise their families, etc., etc. And I didn't think that was necessarily the case, because I remember being with colleagues in my junior years, you know, where all of us were interested in surgery, but somehow along the way it became more and more difficult to pursue it. And then also, if you look at certain subspecialties like breast and endocrine, for instance, the ratios are actually reversed. You know, we have something like 60% of breast and endocrine surgeons in Malaysia are female. So clearly it's not surgery itself. And so it's got to be something a little bit more than that, maybe the environment, etc. And then, so I conducted some research where we surveyed surgical trainees, surgeons themselves, you know, both junior as well as senior surgeons from both genders, to try and understand this a little bit more. And there was clearly a disconnect between the two, because when you talk to the senior male surgeons and ask them about maybe discrimination or, you know, disparities between the genders, they will all say, oh, we don't have a problem in Malaysia. We're all very supportive of our female surgeons, etc. You know, but when you talk to the female surgeons, both the junior as well as the senior ones, they would tell you some pretty horrific stories about what they had to go through, and that included bullying, it included sexual harassment, you know, and all those sorts of things. And then when I surveyed the trainees, both male and female, it became clear that actually toxic behaviors in the workplace were not as uncommon as you might think, and it affects both the genders. But certain behaviors were more prevalent in one than the other. So, for instance, the male trainees were more likely to be bullied, but the female trainees were more likely to experience sexual harassment, for instance. Okay, so that was something that sort of made me think, okay, we need to find some way to support and to mentor trainees. And it wasn't really meant to be just female trainees, but because those of my generation that had gone through it, you know, had experienced all this, we felt that we would want to focus on these issues. And it just so happened that it was mainly women who had experienced them. So that's why we formed the chapter.
Right, thank you, Prof. It's a very new thing that we see in this field, because I think only this, well, to my knowledge, there's this women's surgeon chapter under academic medicine. Otherwise, there are no, at this moment, there are no other similar women-led, women empowerment organizations in terms of the healthcare field. Prof, you mentioned
there is another one, which is called WIGNAP. I'm trying to remember what it stands for, but it's basically gastroenterologists.
Okay.
So they do have women. I think it's women in gastroenterology, and I can't remember what the NAP stands for. But there is one in Malaysia, and it's led by Datin Sharmila Sachita London. She's based in Pantai. But also people like Prof Ida and all that are in the group, and they actually usually invite me in as well, because, you know, we're colorectal surgeons, we work very closely with gastroenterologists. Yeah, so those are the two that I know of.
Yeah, in globally we also see movements like gender equity in global surgery by Harvard, and also there's women in global health, this sort of things. But so far in Malaysia, these two are the only one that we see. But you mentioned did not see any when you were back in the days where you were still a medical student, you did not see any female surgeons, female being in surgery. Actually, how is it now? Like how can the specialty in general, the environment and also the uh, workforce be more fair to everyone regardless of gender?
Yeah, so part of it is a pipeline issue. So obviously, if you start having more enrollments in medical school, you would expect that the proportion would increase. And it is true that certain specialties are more attractive to some than others because of the nature of the work. But what we want is that people who are interested in the field should not be discriminated against or disadvantaged because of their gender. And interestingly, in the work that I did, it wasn't just toxic workplace culture that was a problem. We also found that it was societal expectations. It was actually with the situation at home that was making it untenable for some of these women to continue in their training. So it would be things like, the parents or the in-laws who were unhappy that the daughter was spending so much time in the hospital, or there was not enough help in the home. And so these women actually give up their careers, having spent quite a lot of time training already. Yeah, so it's quite complex. But what we can do is number one, we can try to work on the hours, and so that's where you have more people coming into the field. The number of calls is not so onerous. The hours are also better. The work is shared. Also, by taking a more team-based approach, it means that as long as every member of the team is trained to do things, it doesn't mean that you have to do every single thing for your patient. You can share that workload. I think that's made a huge difference, because I came from a generation where if you were treating the patient, then you had to do everything. You set the line, you put up the drip, you take the history, you did everything from beginning to end. And that can actually be quite taxing. And I know many of my senior colleagues, they actually ended up burning out and developing all sorts of health problems because they felt like they had to be so obsessive about it, and do every single thing for the patient. And that's not healthy for anybody, right? So we've changed that approach, and that makes it a little bit easier. Also, when you have enough staffing numbers, you can ensure that everybody has time off. So I usually make sure that no one on my team is working without a break. We now get to have at least alternate weekends where we don't have to come in. I used to have to come in every single day, and this was for more than 10 years. Up until maybe about 10 years ago when I started alternating weekends, and now of course I don't necessarily have to go into the hospital on weekends, but I'm usually working doing other things.
I see. Also, to summarize, in order to improve the gender equity in this specialty, a few methods we can try to work on is the hours, and also the shared responsibility in treating the patient, and trying to ensure that everyone has at least some time off, for example, alternate weekends. Right, so that ends our first section into introducing what is general surgery, and there's this talk about this specialty not being female friendly. So that ends our discussion there. Next, we would like to move on. I believe a lot of the audience here are interested in this topic are the exact steps from medical school, from finishing medical school to becoming a general surgeon in Malaysia.
Right. So what I said before about, at the time I didn't think that I was going to be doing surgery after I got through medical school, right? I suppose we had the luxury then of being able to take our time to decide what we wanted to do, and that might not necessarily be so true now, because it's much more competitive. You have limited training spots, and there's many of you competing for it. And so as you go through medical school, I would encourage you to really immerse yourself in each rotation as you go through it, so that you really get a sense of what your passion is going to be, right? I don't think that deciding on a specialty in the medical and surgical fields is something that should purely be decided on, oh, are there training posts, or will I make a good salary from it, because this is the rest of your working life, and you're going to spend a lot of your time at work. Okay, I spend more time at work than I do at home even now, right? So you have to enjoy what you're doing. So that's why I feel like you shouldn't be making the decision too soon. Use your time in medical school to really immerse yourself in each field, really talk to the people who are working in it, and get their views on what they like about their job, what they don't like about it, and really get your hands dirty, doing the stuff. Don't just stand at the back of the room or at the back of the operating theatre. Get stuck in there. Ask to assist, ask to scrub up, do the call, see the emergency patients as they come in, because then you really get a sense of whether this is for you or not. Okay, so obviously, if you think that you might be related in surgical specialty, so it might not be general surgery, but you know that you want to work with your hands, you want to do some kind of operative field, then I would try, even in medical school, to try and write some papers, in the subject, because now it's not just about having knowledge, but you want to show that you can do some research, you can write, all of those things. And once you're out of medical school, you should start trying to attend workshops and courses that are sort of for basic surgical training. So in fact, now the College of Surgeons, we have launched a basic surgical program by which, regardless of where you are stationed in the country, whichever hospital you're at, as long as you're in a surgical department, and you can identify a trainer that is a member of college, you can actually register to be in this basic surgical training program. We provide you with a curriculum, and there is an electronic training management platform by which you can enter all your workplace-based assessments, and get feedback from your trainers as well. So that's about 2 years, we would say, would be sufficient. And at the end of those 2 years, you may want to attempt an examination. So it could be the MRCS examination, which comprises of the Part A, which is a MCQ paper. And then you have Part B, which is an OSCE. All right. Alternatively, you could sit for the MEDEX, which is the local exam that's run by Majlis Peperiksaan Malaysia, and that is purely MCQ, so it's an SBA type exam paper. Okay, so both these exams actually do carry weightage when you want to enter into a clinical master's program. Okay, and so the common clinical master's surgical programs would be general surgery, orthopedic surgery. Some of you may be interested in ophthalmology or ENT. And they have just recently started a cardiothoracic program also in the clinical masters. Okay, and then of course, for those of you who are surgically inclined, but don't want it to be everything that you do, you might want to do ONG, which has a bit of more medically related components, but it does offer you a little bit of surgical exposure as well. So that will be a pathway to general surgery. Do medical school, do your housemanship, do basic surgical training, and then compete for a place in a clinical master's program.
Right, Prof, if it's okay with you, I see there's a comment, asking a question that is so relevant to our discussion now that I would like to just discuss it now. Is it okay?
Yeah, sure.
Yeah. Okay, so it is okay. It's so long. Okay, it reads, "Good evening, Prof. Can I have your opinion and advices on what we as contract housemen can do if we are really interested in surgery? As far as he's concerned, to specialize in surgery isn't similar as taking MRCP for medicine and MRCPCH for pediatrics. It usually requires master in tertiary healthcare center. However, with us facing the difficulty of getting the permanent placement, what can they do if they are really interested to specialize in surgery?"
Yeah, this is a very common question these days, and there's actually quite a lot to unpack in that question. It's not quite as straightforward as you might think. So the first thing I would say is that training in the specialties in this country is evolving, and some of you may have heard of the National Curriculum Project, which Prof Adiba, my predecessor, was championing. Okay, and we're actually towards the tail end of that project now, and the curricula are about ready to be launched. What has happened then is that it was recognized that there was this disparity in some of the medically related specialties where you could do MRCP or MRCPH and then suddenly you're a specialist. But it was recognized that actually passing an exam doesn't necessarily mean that you are competent to be a specialist. You know, some things are not determined by a piece of paper, right? So what has happened now with the medically related fields is that the national curriculum has now streamlined the training that is required, regardless of whether you do a clinical master's or whether you choose to go the what they call the parallel route, where you do the MRCP or MRCPH. So yes, you might get the exam, but you will still not be gazetted by NSR as a specialist unless you have completed the training. Okay, so for I believe for say MRCP, the time post MRCP it takes before NSR will recognize you is longer than the time after clinical masters in internal medicine. Okay, so that is the general evolution of training in this country, right? So for general surgery, the path to a specialist qualification in this country is only through the Master of General Surgery programs. Okay, and there, you know, there was a particular reason why the training boards decided on this, and it is to do with the fact that it's a craft specialty. You can't just pass a paper and then call yourself a surgeon. You actually need to acquire the competencies, okay, the technical competencies as well as all the non-technical competencies. And that takes time, and it takes exposure to the right number of cases, the right case mix, you know, the right volume, right? So when we work all of that out, we decided that in this country, even if we were just to focus on the master's programs, we would have saturated all the training posts already, so that there aren't really any excess training posts for you to do other types of programs. And you know, because that's the training posts are determined by the number of trainers as well as the case volume and case mix. Okay. However, on average now, it takes someone at least around 4 to 5 years post housemanship to get into the clinical masters. Okay, and that's why we're saying that even if you wanted to get into the clinical masters, you would be spending at least 2 to 4 years, hopefully in a surgical department, getting some basic training. And that's why we formulated this basic surgical training program, which will then allow you to work through a curriculum. And at the end of it, the College of Surgeons will issue you a certificate of completion for basic surgical training, which you can then use as you know, a bargaining chip to either get a permanent post or at least be allowed to go into higher surgical training. And there are currently discussions in Ministry of Health to sort of relax that requirement that you must be in a permanent post before you can be allowed to do training, and to extend your contract so that the contract takes you all the way through the end of your training. I hope that answers your question.
So it is fair now to say that unfortunately, at this point of time, there is, unless the contracts are extended or there are more permanent positions provided by the ministry, the contract positions are an obstruction and it hinders the progression. Is it okay to say that? Is it right?
Not necessarily. Like I said, you can go into a contract position and then get stuck into your basic surgical training because you're not limited by that. Okay, because the basic surgical training is not something that requires a scholarship. You're just working, you're just doing your normal work, but what you're doing is you're recording the training that you get, and there are specific procedures and assignments that you have to complete, right? And you can do that on your own time, actually. Okay, and then things like the courses, the recommended courses like ATLS, CRISP, NOTS, okay, SOTM. These are all recommended courses at basic surgical training level. You can get all of that done, and so when you've got all of this under your belt, you can go to your head of department or to the administrators and say, I want to do surgery, and they should then consider either giving you a longer contract than allow you to get into to apply for a master's program, or offer you a permanent post. You see, the problem at the moment is, how do you weigh up two candidates, because there's nothing for you to show. That's why we came up with all these criteria. If you can do this, it shows that you're interested, it shows that you are capable, and so you deserve to be given a permanent post or at least a training post. It's not easy.
It's competitive, right?
But a lot of it is administrative rather than something that is specialty related. So it's not just affecting surgical specialties. It's all specialties are affected. But people are working on this. We are having the discussions at ministerial level, with JPA and all that. But the civil service is something that is so rigid and inflexible, right? But trust me when I say there are many very dedicated people who are working on this, and we hope that there will be some change soon. Obviously, the pandemic has just thrown a spanner in the works, because now our energies are focused on that. Yeah, but we haven't forgotten you.
Okay. Reassuring to hear that there are people working very hard on to improve the system. Okay, right. So, Prof, looking at the masters is the only way for us, medical students, medical graduates, who are interested to do surgery in Malaysia, to actually become a surgeon. How is the admission like to the master programs? Is it by the individual universities, or is it by a centralized body?
Okay, so again, it's quite complicated, but I suppose the short answer is that the entrance evaluation is conducted jointly. Okay, so we have a body called the Conjoint Board, or actually the correct name is the Conjoint Subcommittee for General Surgery, but everyone just says Conjoint Board. So each specialty has got its own Conjoint Board, right? And basically it is comprised of representatives from all the universities that run the program, okay? And then we also have representatives from Ministry of Health, as well as from the College of Surgeons. So for general surgery, we have 5 universities represented, and then we have Ministry of Health as well as College of Surgeons. Okay, but the programs themselves, the individual programs, are actually run by each of those universities. Okay, because the degree is awarded by the university, it's not awarded by the conjoined board, right? Your master's degree is awarded by the university that you are registered to. But because bulk of our applicants are actually Ministry of Health staff, right? They're most from Ministry of Health, and most of them will, if they get in, they will be coming under a scholarship from JPA. Therefore, we feel that rather than each university selecting its own, and then it may be that some good candidates might in just because they apply to a different university where it's very popular. What we decided, this would have been about 10 years ago, we decided that we would do a conjoint entrance evaluation, and based on the various criteria, we would then rank all the candidates. And then if there were 60 scholarships for that year, we would just take the top 60 regardless of what university asked for, right, as their first choice. And so we just go down the list. If you're number 1 on the list and your first choice was UM, then obviously UM will take you, right? But let's say an extreme example, UM has, say, 15 training posts, okay? And the top 15 all put UM as first choice. I'm dreaming here, you know, but why not? So that means candidate number 16 may have put UM as first choice as well, but won't get in because we've already filled all our slots. So then we look at what their second choice is, and they would get that. Okay. So that's how it's done.
So we can already see the level of competition that one has to get through and to commit to.
There's usually about at the first vetting, and this is the vetting that goes through Ministry of Health, where they just ensure that you fulfill all the administrative requirements, right? There's usually about 300 or so applicants every year. And then once it goes through the first vetting, it's usually count to about maybe 200 or so. And then those 200 would then sit for an exam. We used to run our own exam, but now, we accept the MEDEX if you've got the MEDEX also. Then based on that, we whittle it down further to, say, the top 100. And we call these top 100 for the interview. And that's where we get your portfolio, your CV, what experience you have. And then we ask you in the interview, we ask you some questions to test your knowledge and also your non-technical skills, right? So then at the end of that, we finally select our top 60.
I see. We can really see the level of competition. Okay. Prof, the current number of posts that are available and the spots in the master's program, do you think that it's enough currently to produce this number of specialists at a pace that is sufficient to serve our country?
So again, a very, very complicated question to answer, because actually, to be honest, we are producing something like 70 general surgeons per year, okay? And to be honest, if we retained all 70 for the duration of their working life, we would have enough surgeons. So the issue is actually attrition, so we lose them either to retirement or to private practice or whatever, right? So that's one aspect of it. And so then you say, well, why don't you just train a lot more so that you, mitigate the attrition? But remember, this is a craft specialty, And like I said, there are a certain number of training posts which are determined by the number of trainers, the number of patients, and this mix. Okay, yes, we can increase the number. I can double my intake in UM to, let's say, 25 or 30. But what will happen then is that you won't get enough operating. You won't get enough cases to operate on because the volume of patients is that much, right? So let's say if we say that when you exit the program, you have to have done at least 50 colonoscopies, right? And then in your hospital, the volume is, let's say, just for argument's sake, right? It's 500 cases a year, right? But you have got 50 trainees competing for it because it's third and fourth years. So how are you going to get your volume? That's colonoscopies, which are quite common. What about other operations? What about your splenectomies and your anterior resections and all that? So it is quite complicated, and that's why the number of training posts is not limitless. It's not a case of just sometimes you may have enough trainers, but you don't have enough volume. So we do actually track each of the hospitals that are training sites. And I can tell you that when we looked at the case volume, surgical case volume in UMMC, and we compared it with some of the other teaching hospitals, our volume is actually twice the number of some of the other training hospitals. So if even our candidates are having trouble getting enough cases, can you imagine we go to other hospitals? So we don't want to be graduating people who just have a piece of paper but they can't do anything, right?
Right. So
Yeah.
we always have to take patient safety and basic competency into account. And it is always difficult to balance out when we are talking about increasing more posts, training more people.
Well, actually, I think we're training enough. It's just that we are losing them, right? So we have to figure out how to retain them in service.
The attrition. Right.
Yeah, that's our major problem.
So I was going to follow up with a question that will there be more centers doing master's program, but I think that is answered.
Well, not quite, because yes, there will be more centers. I can think of 2 that have requested, but undergoing the various accreditation processes because of the things that I mentioned. We have to check that they have enough volume, they have enough staff, and all that sort of thing. But there are at least 2 universities that have applied to have a master's program in general surgery. But when they start off, usually they will start off with quite a small intake. They'll maybe take 2 to 4 candidates, and usually it's their own internal trainees because they have to train up their own academic staff.
I see. All right, Prof. So with this, we sum up the discussion on the section about the pathways, how to become a surgeon, and the training posts, what are the criteria to enter, what are the exams. We even touch on the external exams like MRCS, MEDSOC. All right, so for the next section, we would like to explore, Prof, your personal journey on colorectal surgery. So, Prof, before we start off, could you explain to us what is a fellowship in surgery? How does that play on what level of career that do we go for a fellowship?
Okay, so I'm going to refer to the situation in Malaysia because this should not be confused with the fellowships that are awarded by the Royal Colleges of Surgeons in the UK. Okay, so that is an exam that you sit, and at the end of it, you are awarded this diploma or fellowship of one of the Royal Colleges. The fellowship program I'm talking about is the one in Malaysia, which is for sub-specialising after you've already obtained a primary specialty. Okay, so let's say your primary specialty is general surgery, you then want to sub-specialise in colorectal surgery. Okay, or let's say if you did orthopedic surgery. That was your primary specialty, is orthopedic surgery, and then you decide you want to subspecialize in spine surgery, for instance. So the spine surgery thing would be a fellowship. Okay, colorectal surgery would be a fellowship. In Malaysia, the standard clinical fellowship program is 3 years in duration. Okay, but it is not a degree or a university degree. It is a professional fellowship. It's a professional training program. Okay, so it's 3 years, and it used to be that we said you had to spend 2 years in Malaysia with at least 2 different trainers, and then 1 year abroad. That has now been relaxed, partly because it was felt like we had enough expertise in the country that it might not be necessary to go abroad. But also, going abroad is quite expensive, and at that stage in your career, it can sometimes be difficult to relocate, when you've got family and all that sort of thing. So it was relaxed a little bit. And now, obviously, with the pandemic and travel not being an option in many cases, we relaxed that further. So there will be those that conduct or complete their clinical fellowship entirely in Malaysia. Okay, so it's always the case when you go through different levels of training. You finish medical school and you kind of think, yeah, I know everything, right? I know so much already. And then you go to the next level and you realize you don't know anything at all. So that's the way it is with each stage. You realize how much you don't know, which is good, so that we don't get too arrogant or too overconfident. It's always good to be humble as a surgeon.
All right, Prof. Prof, you did your fellowship in colorectal in Singapore. So would you like to share that experience to us?
Yeah, so how I ended up going to Singapore was actually a bit of serendipity in that. In those days, again, I really don't like telling you how old I am, but in those days things weren't really quite as organized. It was, the pathways weren't really clear. You kind of had to make it up as you went along. You had to kind of craft your own career pathway. So now it's a lot better because the pathway is much clearer. So what happened was the year before, I had the opportunity to attend a workshop in NUS, and during that time, I actually met the consultant who would end up being my mentor. That's Charles Sang. And so in the chats that we had, he did mention that they did train colorectal surgeons. And then what happened the following year was one of my colleagues was offered a training post, a fellowship in NUS, but I can't remember why, but he wasn't able to go. So he said, would I like to go in his stead? And this was actually at very, very short notice. It's not like I had months to prepare. It was weeks, and I had to think about, where am I going to stay? How am I going to relocate? And then I had to sort out release from at that time as well. So it was actually quite challenging. But at the time, Tan Sri Amin, our former vice chancellor, so he was dean, and he was very kind, and he said, don't worry about the administrative aspects. You just go and we'll sort it out remotely. Okay, so that's how I ended up in Singapore. The Singapore fellowship was more like the fellowships that are done around the world, where it is usually a 6 month to 1 year attachment. It's similar in the US as well. After you do your general surgical residency, you can do a 1 year attachment that you call your fellowship. Okay, so it's quite intense because you're supposed to get all of this experience in that 1 year. But that was where I really had my first exposure to sort of a higher level of care, because at that point in time in Malaysia, it was still very much just general surgery. And then you might say you have an interest in doing breast or whatever, but you were still practicing pretty much as a general surgeon. So that was my first exposure to what a full-time colorectal service was like, and then I realized again, oh, I don't know anything. And I had to learn again about a whole lot of things. But it was a life-changing experience, as I said, because that was the first time I saw that. But also, I think being mentored, that was the first time I really felt mentored in my career, because I was told, okay, yes, you need to be technically skilled, but you also need to be able to sort out the academic aspects of things. So, how you conduct clinical research, how you write papers, how you write reviews, and then they were very good getting international exposure. So although I was in Singapore, but I was given some funding to actually attend big conferences in the US and encouraged to present there. And then that was where, I met people like Steve Wexner and Conor Delaney, and all these big names in colorectal surgery. And I suppose that ultimately in the end led to where I am today, where the American College of Surgeons recognized my work, because I have been networking with them all these years. So it's not something that happens overnight, I'm afraid. It's a lot of hard work, a lot of traveling, a lot of networking.
All right, Prof, congratulations on the fellowship from the ACS again. And Prof, did you when you were going to Singapore, did you choose specifically colorectal surgery, or was there just an opening at the time, so that was the one that you chose?
No, I chose colorectal surgery. Well, the fellowship was for colorectal surgery, but I went because I wanted to do colorectal surgery.
I see.
That was what I had developed my interest in. When I first finished general surgery, as I said, I actually spent 2 years doing general surgery. That means doing everything, doing breast, doing thyroids, doing abdominal surgery, etc. I was doing esophagotomies and things like that as well as some vascular surgery. So you're kind of a jack of all trades. You do a little bit of everything, but you're not doing it to the highest skill level or complexity level. You're doing things that are safe and within the remit of a general surgeon. So having done all of that, I did find myself drawn to the colorectal surgery area. And at that time, it just so happened we didn't really have a colorectal surgical service in UMMC. We had a general surgical service that did some colorectal work, but it wasn't really a colorectal service. And so I felt that would be a good field and expertise to bring back and develop in Malaysia. That's why I chose to do that. We already at that time had quite a well-established breast service. Prof was there, and Professor was there. So I felt like it didn't make sense for me to also do breast, because we already had a well-established unit. What would have brought value is to develop a new service.
Unit, service.
Yeah. But it also happened to jive with my own passion, which was fortunate.
And also fortunate that the opening itself was colorectal surgery for the fellowship.
Yeah, that's why I say it was serendipity, just things kind of happen at the right time for me.
I see. Prof, so talking about subspecialties, do we in Malaysia need more subspecialists in all those fields of general surgery?
Okay, so yes and no. All right.
Okay.
Whatever specialty you look at, whatever subspecialty you look at, we don't have enough. Right?
Okay.
But if you look at National Health Service as a whole, do we need everyone to be a subspecialist? No, we don't, because actually it's just like, do we need everyone to be a specialist when it comes to medical fields? Actually, no. The bulk of our needs are actually in primary care, and in fact in preventative medicine. right, rather than the higher end specialist care. So yes, we need more sub-specialists, but we actually also need a lot of generalists also. Okay, and for most of the hospitals in Malaysia, you probably don't need a full complement of specialists and subspecialists, but you do need generalists. Okay, so that's why general surgery is still very, very in demand. And in fact, in smaller hospitals, in more remote areas, what you want is actually a generalist who can do everything, and you just need to have a few of them there, and they can do your burr holes, your craniotomies or your craniectomies for the trauma, the head injuries. But at the same time, they can also do a thoracotomy to evacuate a hemothorax. They can do a laparotomy, and in some instance, certainly even during my time when training, a general surgeon might even fix a fracture. I think that is no longer the case because we produce enough orthopedic surgeons that you would usually have an orthopedic surgeon in the hospital. But yeah, it's not that long ago that general surgeons were fixing fractures as well.
I see. I didn't know that was a thing previously.
Yeah.
All right, Prof. Since we are talking about fellowship and Singapore, our close neighbor, we're also aware that the Singapore has also adopted a residency program. Like after they finish their medical school, they can either straight away start residency year one, or they could go for 1 year housemanship and then come back as residency year one. So that actually, from my knowledge, it speeds up the production of specialists. But I understand that when we are speeding up things, we might lose quality, we might lose experience. So do we, in the foreseeable future, do Malaysia will also follow the path of having a residency program?
Okay, so why are you asking me all these very, very complex questions? So the first thing to say is that the healthcare environment in Singapore is quite different to ours. Okay, in fact, in terms of specialists and training posts, to some extent, certainly in some hospitals, it's quite saturated already. Okay, so although you're correct in that it is possible to go straight into residency after you graduate, the truth is that it's quite competitive. So it's not a given that just because you want to do surgery, you'll get into it after medical school. Okay, so it is still competitive. That's number one. Number two, what I found certainly when I was there is that the volume of cases is actually not as high as typical hospital here. But again, it depends on which hospital you go to. Certainly, trauma related thing is really, really uncommon. I think I was there for a whole year and I only heard about 2 trauma cases during my entire time. Okay, so that there's some good and there's some bad. The volume may be not as much, and then certain kinds of cases might not be so common also. Okay, but if you're in a big center like SGH or NUH that has a very specialized colorectal service, then they kind of concentrate their cases there, so you'll get a good experience. The problem is that because the residency program is very it's very structured and very organized, and you're supposed to undergo assessment every year. But the assessments might not necessarily reflect what your actual competencies are, so it only trains you to get to sort of a minimum skill level or minimum competency level. So people coming out of the program, the feedback I've had from my colleagues who are trainers there is that, okay, they might be sort of competent, but they're not really confident because they haven't done enough. Okay, because if you think about somebody going through the clinical master's program in Malaysia, they've done housemanship, okay, and then they've done probably 4 or 5 years in a general surgical department doing sort of MO work and all that, but getting exposure to operating. Most of them, by the time they come into masters, they can already do an appendectomy, herniectomy, hernioplasty, emergency laparotomy, do a PGU and all that. So they can already do that. Some of them can already do upper scopes. So it makes it easier for us then in the masters to take them to the next level where they're doing more complex operations, managing more complex patients, etc. Right? So imagine you're trying to do that, which essentially works out to about 8 years? Yeah, 4 years before and 4 years in the program, 8 years of experience, and now you're trying to compress that into 4 or 5 years. There's this thing that we throw around in surgery. It takes 9 months to make a baby. What happens if you deliver your baby at 7 months? A lot of problems, right?
Lots of problems.
Yeah. Yeah. So I'm not saying that it's entirely time-based, but the time does allow you to acquire more experience and improve your not just competency but your confidence in your ability. And that's really essential when you're trying to lead a team.
I see. Prof, I feel that we keep coming back to this. It is not just a paper. It requires, by graduating as a specialist, as a master's graduate, we need to be able to uphold patient safety and also have our basic competencies. So I feel that we keep coming back into this now. We are at a different topic, but again, we are talking about it is not just a paper, but it is more of how much can we, how competent are we, and the experience that we get.
Yeah, absolutely. And I think that's something that the medical specialties are starting to come around to, because for the longest time they were just thinking about the exam, But as medical specialties also start becoming more complex, more sub-specialized, and some of them are now more interventional as well, it's clear that you cannot just rely on a paper exam, right? It has to be about, can you deliver as a professional? Can you do what your degree purports that you can do? Okay, there's nowhere to hide, and that's the thing about surgery as well. To some, it might seem a bad thing, but I think it's great. There's really nowhere to hide when you become a surgeon. You cannot fool people for long. You either are good at it or you're not. Right?
Right.
Yeah. So we don't want to be qualifying people who cannot perform as expected.
Right. It is not safe for everyone, the patients as well.
Yeah, and it's damaging to patients, yes, but it is also ultimately it will be damaging to the person themselves. Okay, because you get into all sorts of complications. You may be sued. You may lose your career because you weren't good enough in the first place. Right.
Right. Okay. Thank you for sharing that to us, Prof. Prof, now we try to look into the academic side of surgery and also some admin side of the job. So, is it challenging for a clinical surgeon in teaching hospital to do research, not just teach undergraduates, but also the postgraduate students and research at the same time?
Short answer, yes.
How is the, and then I would like to follow up on that. Like, how did you do it for like so many years repeatedly?
With great difficulty, and I would say that if you look at my career, it must seem that for the longest time, nothing was happening in terms of academic progression. Yes, I was a surgeon, but there didn't seem to be any papers coming out. There didn't seem to be any research projects, and that's because you were just inundated with clinical work, and there weren't enough of you to go around. Like I said, we're doing 15 calls a month. you really don't have any time to do anything else. Plus, we didn't have a big staff number, so there weren't a lot of senior staff to help mentor you through your career. You need to tell you that, okay, yes, you're busy, but maybe you can collaborate with me on this project, and I'll help you with your writing skills. I never had any of that until I went to Singapore, where they had a much bigger staff. It was all very, it was a mature setup, both in terms of the clinical as well as the academics, right? So that's why I say going to Singapore was life-changing, because then I realized, okay, this is how it's supposed to be. This is how you're supposed to be mentored and how you mentor others as well. And that's something I've really tried to bring back with me. So I mentor not just colorectal surgeons, but all the staff in the Department of Surgery, that if they have been under me, I do try to mentor them in terms of telling them what they should do at this stage of their career, put them in contact with the specialties that they're interested in, find them opportunities for training, etc. And that, I would say, is another sort of less publicized part of being a surgeon, right? It's not just about you, it's about what you give back and how you bring the next generation through. And this is something that I think, particularly in surgical specialties, that mentor-mentee relationship is very, very strong. That's why you will hear until today, if you take a famous surgeon, say like Datuk Kandasamy, you always hear about, oh, that's Kanda's boy or that's Kanda's girl, because they trained under him, and they would also be very appreciative of him. Similarly, Prof Yip has got her boys and girls, right? And I apparently now I also have my boys and girls that have been mentored or trained by me, right? And that's something really, really special. It's like you're part of this big family. And again, that's one of the other things that I really like about surgery.
I see. Prof, is it how is it like for surgeons to step up to take up administrative works? Is it a thing that is just part, because becoming a surgeon, we said earlier that one of the essential skills is to being in a team and able to have some non-technical skills. So we are seeing that our DG is taking up who is also a surgeon, and Prof yourself is also a surgeon taking up as the dean. So is there a connection between these surgeons and taking up administrative posts?
Yeah, so if you're a good surgeon, you need to be able to lead a team, right? And leading a team is it is actually a skill. It doesn't mean that you need to be the one making the decisions all the time, because there are certain situations where because you're focused on, say, an emergent development in the surgery, you develop tunnel vision, and so you might not be the best person to lead at that time. It might be the anesthetist who is calling the shots during that time. But in general, you need to be able to coordinate the team, okay? And part of that is anticipating what's going to happen. We always have a plan A, a plan B, a plan C. If this happens, then I'm going with plan A. If this happens, then I'll need to switch to plan B, etc. And we always think about what go wrong, okay? What complications are going to happen, and then you anticipate that and you prepare for it, right? That's why so much of surgery is actually planning, okay? And I think that's why inherently we tend to be quite good at organizational leadership, okay, because it's what we do anyway in day-to-day life. But of course, the specifics of administration, that's something that we have to learn. The systems, for instance, the hierarchy, the workflows and all that, that is something that you have to learn. And that's something that I feel should be better trained, because oftentimes what happens is that you become a head of department or you become a head of unit just by virtue of being the most senior person, but you don't necessarily have the skills or the expertise to do it well, right? And so that's one of the things that I'm looking at during my tenure as dean, is to try and establish more formalized and structured training of leaders. Might not be surgical, but just leaders in administrative role. Okay, so that they can lead better.
And those leaders do not necessarily have to be the eldest person in the room and in the team.
No, I've seen very good leaders who are considered junior, and I've also seen really bad leaders who are very senior in their field. It's a skill, it's a competency that needs some training, and there's some people that are naturally better at it, but everyone can become better if they are trained in it.
I see. Okay. All right, Prof. Just a few more before we move on to take. There are a few questions in the comments. So next, we'd like to ask if Prof, is it possible? Two questions. So is it possible for surgeons to have a family life? And then what are some of the challenges that you have faced in balancing between administrative, academic, surgical field and your roles at home? Yep.
Yeah, absolutely, it's possible to have family life. Plenty of surgeons do have families of their own, and those that don't, oftentimes it's a choice that they decide not to have. But this is where you have to be able to balance your life. And I know this phrase work-life balance gets bandied about a lot, but it really is too simplistic. Okay, because it gives you the impression that, okay, you can work out in a day. I'm going to have X number of hours where I'm at work, and another Y number of hours that I'm going to be with my family. And it's not really as simplistic as that. There will be times in your life where you will have to focus on work more than your family, and there will be other times where family has to take precedence. What you want, though, is that over the course of your entire life, there is balance. That you have been able to have loved ones around you, that you've managed to maintain your circle of friends, that your life is not just about life in hospital, that you have traveled, that you have explored other passions, outside of your field of work. So to me, that is what work-life balance is about. And so again, as with everything else, it just requires planning and organization. Okay, but I'm not gonna lie, it is difficult, particularly during training, and particularly when you've become a junior surgeon in a place where there's not many staff to share the workload. Okay, because then you're responsible. You're not just a trainee, you're actually responsible for other staff, and you're responsible for the patients. Okay, so that's where, if you want to have a family, the home support is actually extremely important. I was very fortunate in that with my son, my firstborn. At that time, I had just gone into, I was working in a cardiothoracic department, and I was on call about 3 to 4 times a week. Okay. And so then after I delivered him and I went back to work after maternity, I think the senior MO decided I had to do 5 calls that week. So straight back from maternity leave, straight into 5 calls. So you can imagine it was quite difficult. I had very supportive in-laws who were looking after my baby while I was at work. And my husband would come when I was in the hospital at night. He would come to collect my breast milk, basically, that I had pumped for my baby. So there was a lot of work that was going on behind the scenes at home. Not everyone has that kind of support. And when I joined the master's program, I had to move down to KL, and so I was separated from my husband, but my parents were in KL, and so I was able to stay with them, and they helped with the childcare. And I don't think you can underestimate how important that is. I was telling you about some other women who had started training and then gave it up. So one of them had actually, passed her MRCA Part A and Part B, and had done some research as well, and had actually managed to get a place in the master's program. Right before she could start, she was told by her mother that her mother was no longer going to be able to look after her children for her while she was at work. And so she gave it up. And I think she decided to become a GP. That was after putting in probably about 8 years into trying to have a surgical
hard work.
career. Yeah.
So
Yeah.
it is difficult. It is difficult.
And we have lots of stories of families breaking up, even cases of domestic abuse, even to the extent that police have to be called to the house. So I'm not saying everybody is going to go through this, but you have to go into this with your eyes open. It is not easy. It is not easy. And your whole family has to be board with this. Otherwise, it leads to trouble.
Right. It's like going into a surgery where there needs to be informed consent of the potential risk that is. Yeah. Thank you, Prof, for sharing that to us. Now we would like to take some questions from the audience. There's one from KC. He is one of our final year students here in UM. Hi, Prof April. May I ask what's the art of surgery that intrigues you?
It is just the beauty of the movement and the appearance. If you paint, for instance, or if you play a musical instrument, that yes, there are the technical bits, but there's just something else that comes with having an eye for beauty, or hands that can craft something beautiful. And I just like the fact that surgery allows me to take the science, whatever is evidence-based and whatever is scientific, but then still apply my own touch to it, and get a superior result. So I'm not sure if that answers your question, but that's essentially what it is to me.
Thank you, Prof. There's another one from Riza William asking, hi, Prof. You mentioned previously that medical students should start putting effort as early as in medical school, if at all are interested in surgical specialties, through writing paper and research. And he would like to inquire and for further elaboration on how to do that.
So what I would say is that you need to find yourself a mentor. That would be able to help you to identify what areas you might be able to realistically do as a medical student. So sometimes we have projects that are ongoing, and it may involve something fairly simple like a clinical audit or something like that, where you could help collect the data, analyze it a little bit, and then publish a paper on it. So I would say find yourself a mentor. That would be the best route in, particularly since you don't have a lot of time within one specialty, right? You have to move around your different rotations. So I've certainly had medical students that have written papers with me and gotten them published. So it is definitely possible.
I see. Thank you, Prof. So there's another one from, I think this is the last one. Okay, this is not last one. This is from John Tan asking, hi, Prof. Can a left-handed person be a surgeon? Does a left-handed person face any difficulty in becoming a surgeon?
Yes, I do have colleagues who are left-handed. Do they face difficulties? The main difficulties is because most of the instruments that we have are made for right-handed persons.
The needle holders,
Yeah, but you can actually order or procure instruments that have been specifically constructed for left-handed surgeons.
Right, Prof. I'd like to follow up that. Is it important also to be able to use your non-dominant hand in a very dynamic manner?
Yes. Yes,
Okay.
when I operate, I use both hands. Okay.
Right.
Certainly, when I'm tying knots, I tie knots with my left hand. And suturing, I tend to do with my right hand. But if I had to, I could do it with my left hand. It's just not as fast as the other side. But there's something that I can do equally well with both hands, and that's something you train yourself to do. It's not that I'm naturally born
I
ambidextrous.
see.
You train yourself, and not everyone can do this. Not all surgeons do this, because you get comfortable, right? And then when you're comfortable, you are reluctant to stretch yourself. But there have been many instances where that ability to use both hands has been very helpful in terms of operations and preventing complications and so on. So
I
I would
see.
say definitely try to become ambidextrous.
I see. All right. Thank you for answering that, Prof. Last one from one of my colleagues is a fourth year student in UM. Raymond asking, good evening, Prof. In your experience, what area do you find most applicants to the master program lacking? And do you have any recommendations?
Well, most of the time it's because they come to the interview grossly unprepared, and I find this bizarre, because it's so competitive, and you should uh, uh, come prepared because the criteria are all out there. It's available in the public domain. You know what we want from you, and yet you don't come prepared. Simple thing. When you go for an interview, you're supposed to be projecting a professional image. So if you come and you're unkempt and you've got buttons undone, you're not wearing a tie, you're looking scruffy, it doesn't already from the outset we're thinking this person can't even handle their lives at this stage. What happens when we put them in a very high pressure situation? Are they going to fall apart? Okay. And then we say bring your CV, and what we get is like loose pieces of paper that are flying all. It's not properly organized, it's not properly ordered, it's very sloppy. All of these speak to your ability to be able to provide high level professional care. And so if you're not demonstrating that, we're not going to take you in. And then when it comes to the specifics of what we're looking for, um, your logbook. We look at your logbook and we see that you've done, say, a couple of appendicectomies, and we say, right, so can you talk us through how you would do an appendicectomy? And you can't do it. And then we're thinking, well, but you've done some, so why can't you even talk about something that you've already had experience of? So that sends up red flags. And then remember, we will also be comparing you to other applicants. And if I have an applicant that's coming in, has 4 years of general surgical experience under their belt, has published 3 papers, has done ATLS, CRISP, knots, SOTM, all done already, and they speak well and they project well, I'm going to take that person, right? Okay. So
Yeah,
then,
just
yeah,
when
and
there
and
is a
and what
comparison.
it's not just it's a comparison, because these are objective markers, right? When we're giving weightage for each of these things. So if you don't have it, then you definitely are going to lose out. And what baffles me is that when candidates are unsuccessful, or sometimes we will actually tell them in the interview, well, it's good that you're interested in this, but you haven't done this yet, you haven't done that yet, etc. Maybe you ought to try and get that under your belt before you come for next year's interview, right? And then next year we see them and they haven't improved their CV at all. There's been no change in the CV. Okay, so rule of thumb, what we normally say is that you should update your CV every 3 months. All right. And there should be, in 3 months, there should be something to update. If you don't have anything to update, it means you're not doing enough.
Right.
Okay. So it's
Three
got
months
to be
rule.
constant striving for improvement.
Right. And failing one interview, I mean, being not able to join the master program this year, should not stop you from trying again in the next year. And within that 1 year, we should also try to improve ourselves. Right,
Yes,
Prof,
absolutely.
we are trying to close soon. We just have 2 more questions. If you could just very quickly answer them. There's Ethan Lim asking about what advice would you give to those challenged and interested in surgery? Yeah.
If you're coordinationally challenged, then maybe surgery is not the best field for you. But that's a very general statement, because I would want you to clarify what you actually mean by coordinationally challenged. That there are many fields of surgery. Not all of them require highest level of fine motor skills. There's certainly those specialties that are much more what's the word I'm looking for? That it's
Less
not
demanding.
so fine. Not less demanding, but the work is maybe less fine. So some branches of orthopedic surgery, for instance, they require much more strength rather than fine skills. So not hand surgery, because hand surgery you need to have very good hand skills. So it depends. But at the end of the day, if you hold a scalpel and your hand is shaking so much that you can't even make an incision, then maybe surgery is not for you. There are some people that they have anxiety, and that causes them to have the tremors, and sometimes medication can help. But if it's hard enough as it is, why do you want to throw in some physical or mental challenges as well? Okay, but in some instances it can be overcome. I would just say that you're just adding another obstacle to achieving success.
Okay, thank you, Prof. Just the last one is Vernon. I keep asking whether will USMLE be considered as one of the strengths when admitting a candidate into a master's?
So we don't actually have many applicants that come in with USMLE, but it would be considered on the same sort of weight as what we would consider MRCS, for instance. Yeah. The problem with the USMLE is it's quite generic, whereas MRCS is more focused on surgical specialties, so it's more relevant to us. Yeah.
Okay. Right, Prof. I think that is all for the questions from the audience. Thank you everyone for tuning in. And I would like to also take the opportunity here on behalf of the UM Medical Society and medical students here, really appreciate and just so happy that Prof. April can join us today. So thank you, Prof. April, for joining us today and sharing so much to us. There are so many sides of general surgery that we only manage to hear and take a glance at it just by only by during your sharing today, this session. Thank you, Prof.
It was my pleasure, and I hope it was useful. And if you have any other questions about it, I'm happy to meet with you, or just email me or something, and I'll try to answer your questions.
All right, Prof. Just as a closing remark, congratulations on the appointment as our new Dean of the Faculty of Medicine in University of Malaya. As our Dean, do you have any words to the medical students who are watching with us now?
Yeah, I do. Let's see if I can put it in a succinct statement. So I think whatever you decide to do eventually, it may or may not be surgery. I think you need to find your ikigai, and that's a Japanese concept that says you must love what you do, but you also have to be good at what you do, and it has to be something that the world wants, and that you can make a living out of. So that's why I was saying, you can love surgery, but if even after trying you're not good at it, then maybe it's not for you, or you can find something else that allows you to be in the surgical world without you actually being the surgeon themselves. Okay, so
Okay.
find your passion, follow it, and get good at it, and you'll be able to make a living.
Okay, ikigai. So today we learned a very new thing. All right, thank you again, Prof April. So I think that is all for our sessions. Thank you everyone for tuning in, both my colleagues from UM and also those from outside of UM. So we will be sending a feedback form. Please help us to fill that in so that we can improve our sessions in the future. And also stay tuned for, as there are more sessions to come. This is not the last session. So to Prof April, thank you again. And to everyone, take care, stay safe, stay at home if you have nothing important to do. Right, thank you, Prof. I think we'll end it here. Okay, Prof.